Peace be upon you, my friends. We will, in my channel, we will discuss simple and direct way for diagnosis a lot of disease. And in the first video today, we will discuss if patient came to you, young patient came to you with hypertension, you will be right prescription antihypertensive medication direct for him or her, or you will be search on the exact cause and give the correct treatment for him or her. So we will discuss briefly how we can be approached by the case of secondary hypertension. All right? Young patient came to you with high blood pressure. In this page, we will summarize the how can I approach for this patient. First, I ask about weight. This is key for this patient. If patient say to me, oh doctor, I increase in weight in last years or last months, so I suspect maybe this high blood pressure due to secondary cause like acromegaly, like Cushing, like hypothyroidism, or simple obesity or preeclampsia of women and pregnant women. If patient say to me, no doctor, my weight is not increase, but my weight is decrease. So my weight is decrease. So that's mean maybe I put in my mind maybe hyperthyroidism, maybe few chromocytoma, maybe due to stress. Patient is working in the stress media, and this is lead to increased stress hormones and loss of weight and hypertension. Patient say to me, no doctor, I am not increasing weight, I am not losing weight, my weight is not changed for a long time. So I think, put in my mind, maybe kidney, maybe other organs, maybe kidney, maybe heart, maybe drug, maybe habit. And you should put in your mind any patient with hypertension should be exclude kidney. Kidney is the major part. Secondary hypertension is about 5% of patient of hypertension. 5% is secondary hypertension. This from this 5%, 4% is due to kidney. That means kidney is responsible about 80% from cause of secondary hypertension. And what causes the kidney? Maybe adult polycystic kidney, maybe glomerulitis, maybe renal artery stenosis, maybe Liddle, maybe Crohn's, maybe Liddle, maybe renal artery stenosis and glomerulitis and polycystic kidney. Other organ, maybe heart, maybe drug like steroid, like estrogen and steroid and cyclosporin, maybe habit like alcohol, smoking and licorice. Here in this three, when we suspect renal artery stenosis, Liddle, Crohn's, if there is hypokalemia, and if there is symptoms of hypokalemia, we will do renin and aldosterone, and we will discuss this in some details later on. But when we suspect hypokalemia, a patient feeling from fatigue, weakness, constipation, abdominal distension, and cramp or arrhythmia. All of these symptoms of hypokalemia. If there is symptoms of hypokalemia, I will analyze the potassium level. So in this chart, this is summarized all causes for secondary hypertension, and we will discuss in some details later on this chart. So if patient say to me, oh doctor, weight is increased, and I see this picture of this patient. So when I look for this patient like this, and he said to me, doctor, weight is increased, and this patient may be diabetic, and hypertensive, and maybe there is osteoarthritis, but is a characteristic facies, prognosticism, and prominent bones. I suspect this patient is acromegaly. So if I see this patient with hypertension, what will I do? Will I do maybe insulin growth factor 1 oral glucose tolerance test and measuring growth hormone, and MRI pituitary to exclude adenoma or pituitary adenoma. All right. This first patient. If I see is second patient, no, this patient is like this. Patient is young and hypertensive, and also at the same time there is like moon face and buffalo hump and striae in the abdomen. So I suspect, oh, this is hypertension secondary to Cushing. So what investigation I will do for this patient? Investigation I will do for this patient, basic investigation, overnight dexamethasone suppression test, and I will be discuss all these details in other videos in some details. Third patient, if I see this patient like this, the patient is dull and also obese, so I suspect this patient no, is hypertension here due to hypothyroidism. So I will do TSH here to exclude or to confirm my clinical diagnosis. I not found characteristic faces like this, but I see the patient is obese like this, and here abdominal obesity and waist. So I suspect maybe this patient here hypertension due to obesity, or also this secondary cause. And if this patient lost weight by about 10%, may become return to normal, so it is treatable. If also patient here is increasing weight due to pregnancy and give history of pregnancy, so that's mean here cause of hypertension due to secondary cause and is pregnancy, so this patient is preeclampsia. All right, all of these patient is increase in weight. Second type of patient say to me, no, my weight is decrease, not increase. So I put in my mind maybe this patient is thyrotoxic. So is patient thyrotoxic, I examine the neck for exclude goiter or measuring pulse, and if I suspect from the history of the thyrotoxicosis, I will do TSH, right? Another one, if patient give me from history 5B, like pressure is hypertensive, patient complaining from headache is an attack of not continuous, but attack of headache and sweating and palpitation and pallor is attack. This is headache and hypertension common attack and resolved. So this give me this picture, this clinical picture, give me idea about maybe this patient is pheochromocytoma. So I do for this patient investigation urine or plasma metanephrines to confirm my diagnosis. If the patient not give me history like this, but patient is work in a stressful position and all the time it is under stress, so that's mean hypertension due to stress hormones like underlying stress hormone continuously like cortisone, epinephrine, adrenaline, like this. So this patient, that mean maybe stress lead to also to secondary hypertension. Third groups say to us, no change in weight. My weight is stable. For a long time, doctor, my weight is stable. So I should be exclude kidney. Kidney, how can exclude kidney in the cause for hypertension? Should be I do first abdominal ultrasound. Abdominal ultrasound is a cheap and good machine to exclude a lot of disease like polycystic kidney. I see echogenicity of the tissue, size of the kidney, and this give me notes for a lot of things. Another things other than abdominal ultrasound, urine analysis. To exclude glomerulonephritis, I look for urine analysis for bast cell and RBCs like this to exclude or confirm maybe patient is complaining from glomerulonephritis. and I will do also potassium level. Potassium level here is very important, potassium level, right? Where it is potassium level, if low potassium level, that's mean if low potassium level, I will do plasma renin and plasma aldosterone level. But plasma renin and plasma aldosterone is so expensive. All right. If I do if potassium is low, I will do a plasma renin and aldosterone. Here renin and aldosterone, if both is high, that means R, renal artery stenosis. Then both is raised, that means renal artery stenosis. Both low, that means little. If aldosterone is high and renin is low, that means Crohn's. So this is start by R, letter R, that means raised. Letter L, that means low, right? But is I said before, is analysis is so expensive, so I should not start with both analysis. So if potassium is low, so here I said if potassium is low, right, I will do renal level. Isn't so? I will do renal level only, not both. I will do renal level. If renal level is high, that means renal artery stenosis. So that's enough for diagnosis. And after this, I will do MRI angio and like this. If renal level is low, yes, here in this position, I should be do aldosterone level. So if aldosterone here is high, that means Crohn's. If aldosterone is low, that means, like I said before, little or other. So if aldosterone is low, maybe little. But I will give here MRA response, that means I will give aldactone. If aldactone is blood pressure become response, and here is response, if response or not response. If not response, that means little. So here, if patient, I will give aldactone and blood pressure is still high, that means little. If I give aldosterone and aldosterone response and blood pressure become decrease blood pressure, that mean maybe congenital adrenal hyperplasia or apparent mineralocorticoid excess. How can I differentiate between both? I will do dexacortisone, deoxycortisol to cortisol ratio, right? Where the deoxycortisol level become high in congenital adrenal hyperplasia but low in apparent mineralocorticoid excess, all right? If patient aldosterone level is normal, that means is Croydon syndrome, right? So another cause here, other than kidney, heart here, renal coarctation of the aorta. If coarctation to aorta, narrowing of the blood vessels here, like this. How can I clinically see this patient? Strong pulse, I will pulse is strong, and hypertension in upper extremity, diminished or delayed in femoral pulse. I will palpate the pulse in the hand and femoral. I will see femoral delay and femoral weak pulse. And maybe I hear systolic murmurs that as loudest in the back below the left scapula. Other causes for hypertension, drugs like steroid, estrogen and steroid, cyclosporine, or habit. Patient is a smoker and alcohol and licorice. So in summary, quick recap. Last message in your ear, I will say to you, if young patient can use hypertension, what I will be in practical way. And first step investigation, I will do TSH, creatinine, urine analysis, and potassium level. Isn't so? I will do three analysis in blood: TSH, creatinine, potassium level, and urine analysis, right? And I will do two investigation: abdominal ultrasound and echo. Abdominal ultrasound to give me picture of kidney, and echo to see the effect of hypertension, if the hypertension is good or transient or chronic. So echo is very important. So I will see also a change in the there is thickness in the ventricle or no. If there is thickness in the ventricle, that means it's a chronic hypertension. So the X is for important to confirm this is a true hypertension for a long time. So echo here is important. Ultrasound to exclude kidney causes is very important, and do analysis for potassium is very important here. Okay, if all of these become especially this is eco-normal, that means this is not hypertension or this is not chronic hypertension. If potassium is low, open in other investigation. If potassium is low, I will do plasma renin activity like and like last page. If renin is high, that means renal stenosis. If normal, like discussed before. All right. So this is a final message. If a young patient came with hypertension, I will do abdominal ultrasound, echo, and do also blood tests like TSH, creatinine, potassium, and urine analysis. If potassium is low, I will do renin. If renin is high, that means renal stenosis. If renin is low or normal, if renal is low or normal, I will do aldosterone to confirm other diagnosis. Thank you.